So thank you so much for this invitation. I think that this is going to be, first of all, I think two goals we'd like to have with this presentation. The first one is to introduce to you maybe a new way to evaluate devices, and hopefully this is something that you will agree with me. It's a very challenging concept when you have the development of a new technology, how to assess the biological response of this technology. So I'll share with you the experience we have had with using optical coherence tomography for that, or intravascular imaging using the OCT technology. And the other concept is the introduction or the new frontiers in flow diversion, which is something we talked a little bit about earlier today, which is what is the impact of surface modification on the need of antiplatelet therapy. So the important thing about this concept is to see, of course, the evolution. And today we had the opportunity to see a discussion on the preference of using steel coils, and something that we've been very familiar since 1990. But over the years, for one reason or another, there has been a need to develop new devices because there's such a wide variety of pathology that we treat. And the use of flow diversion became available as a concept, I have to say, much earlier than 2011. But it took a significant amount of testing. And I have to say to you that compared to many devices we have, I think that the amount of in vitro and understanding of how the performance, mechanical performance of this device was done prior to approval, and also the approval process, the types of trials that were done to get this device approval, is it's very unique on the aneurysm area. You know, in the aneurysm area, a lot of things have grandfather. And you talk about clips or coils, there are no studies showing that this was actually the best therapy. It's all we had for the treatment kind of thing. But flow diverters had to prove themselves compared to the older therapies, and not necessarily something we see often. The only thing is being the biological response and how the coagulation control is done, and that's something that's been a challenge. But as you remember, we have used the concept of flow diversion is something that I would like to challenge you. If you today could tell me what it means to have flow diversion, is that when you make multiple stents of low coverage together, you have an impact of altering flow from an aneurysm. Maybe you can do one device only, but flow diversion can happen in many different ways. And the modern era flow diversion, it tends to be about 30% metal to artery ratio, but this is something that I'll be glad to discuss and hear your opinions on what means to have flow diversion. I think that there's no question that over the years we have worked tremendously on the concept of going from coronary stents to self-expanding stents, and now flow diverters that are self-expanding platform. But this is an evolution only on design. And we have not, we basically have not seen what is the potential, what's the next frontier after developing so much these devices, what else can we do? And it's true that the amount of trials that you have here also allowed us to understand quite a bit what the current devices do. And Premier, I don't know if you're familiar with this, but this trial we just finished in the United States is to increase the indication from large and giant aneurysms to small aneurysms now. So flow diverters are going to be used in a very wide spectrum of indications nowadays. But then comes Shield, and Shield is basically starting with first in the pipeline platform, but likely will move on into different platforms, is basically the concept of surface modification. Now, why this is so important is because if you look at the use of a flow diverter in the way we know today, 30% coverage, it has shown to us a tremendous improvement compared to the stent and coil information that we had from before. There's not a head-to-head comparison, but if you are able to look at this table and you compare the trials that used the flow diverters, the main flaw of the concept of flow diversion perhaps is we can do better on the complication rate, the morbidity and mortality, specifically thromboembolic events. So we saw earlier today, Dr. Henk is presenting a very complex, very large series of flow diverters, and again, thromboembolic complications. Even though it's an acceptable complication rate, we can still do better in there, perhaps. So we have worked on design, but now how can we do better in terms of protecting our complication rates? The main thing between standing coil or coiling alone is the issue of durability at a complication rate is acceptable. So this is the biggest advantage of flow diversion over any other treatment that we have today for wide neck aneurysms is the occlusion rate and sustainable occlusion rate being much better. This is a very interesting data from a study that pulled the data from all the flow diverter trials using pipeline. It was about over 1,000 patients, but multiple centers, and this is basically showing to you pretty consistently across different studies that over the years there is a progressive occlusion of the aneurysms, and they tend to be durable, and the retreatment rate being pretty low and major morbidity and mortality for a large and giant population aneurysms around 7% on this pooled data. Now, so what is the biggest issue then? I mentioned to you many types of complications. You've seen earlier today many types of complications, but thromboembolic events, it's really the Achilles heel of flow diversion. So this is actually in FDA database. You can see the biggest complaint about stents is instant thrombosis or thromboembolic events. So this is a big deal. The problem with this condition is that there's no one solution to it, and we will see later on today a talk on anticoagulation, is that this is not about only the device. It has to do with the procedure, has to be with the patient. There are many conditions that affect the thrombotic state of a patient. So we have to look at, if you look at these different circles here, the strategies that we have to minimize thromboembolic events has to come as a multifactorial type of situation. Now, I have to pose to you that in flow diversion, the next generation of improvement probably will come from surface modification, and I would like to pose to you that intravascular imaging will help us also on this multifactorial approach to decrease the number of complications we have with flow diversion. Okay, so why I think this is important is that if you look at the surface modification issue, it is something we can do. The technology exists for that. We have in the coronary arteries already some proof of concept of surface modification. So you're not coating the device, you're actually modifying how the device is made to decrease its affinity to form clots, I guess, and look more like a red blood cell. That's the initial concept we have. So this is what this shield technology, by adding this PC polymer to the constitution of the device, so you're not coating the device is not changing in size. So this is a very important concept that you're not making the device harder to use. The device actually should perform the same way as the original device. You're just making the device in its constitution add this PC polymer to it. And that seems to have an impact on decreasing thromboembolic events or the affinity of the blood coagulation cascade to be to the device that is implanted. So the stent or the flow diverter look like the outer membrane of a red blood cell. This is how this looks like. It basically it incorporates into the braid of the stent this PC, and this PC polymer will be basically affecting that thrombogenicity. Some of the studies in vitro, and this is one that's very, I suggest you to take a look. The general neurointervention surgery showed this in vitro study comparing the different flow diverters, one with multi-layers, one with single layer, one in using also dual antiplatelets and without dual antiplatelets to see the impact. And you can see here that if you use, these are the different curves, and you look at comparison, the triangular one is Fred. If you can have the normal pipeline in the square, and the circle is the shield technology, the pipeline with the surface modification. And if you use no antiplatelets, you tend to have a separation between them. As you can see that the multi-layer tend to have a little bit more thromboembolic formation, and the shield technologies, it did better in vitro compared to the regular pipeline. But if you have one antiplatelet, you can also have that separation. But if you use dual antiplatelets, that separation, it doesn't have so much of an impact anymore. So it's showing that there was a question earlier today, can you use a single antiplatelet in a hemorrhagic case and place a flow diverter like Shield? There may be an advantage to that based on in vitro studies compared to the need to use dual antiplatelet. Now, this is, I think, is very telling what is happening in vitro, but if you want to see the picture of this, this is now fibrin deposition, and you can see the difference between different devices, and clearly there seemed to be, even within pipeline, Shield versus regular pipeline, also less fibrin deposition on the device. Okay. So now we have the technology for surface modification. We have some in vitro studies. Let's move into the other area, which is the intravascular imaging, and where we are with that today. I think the most exciting thing is that this is what I'm going to show you today is using a relatively large catheter. It's a St. Jude product, but we have a wire, a 14 wire, that will provide the same type of imaging, perhaps even better, and this is at the neuro level. So a 14 wire malleable that can go intracranially. It allows us to obtain this type of information. So imagine if when you did your flow diverter placement, you could see the strut apposition like this. You could say, do you need to angioplasty or not? But this is nothing. I'll show you even more further analysis on this. You can also, not only in the acute phase, when you deploy the device, analyze if it's a good deployment. You can on follow-up see how much the struts are being covered by endothelium. There's a difference between IVAS and OCT, and I think this is kind of just shows you the spectrum where OCT is in terms of the type of imaging acquisition is a light-based acquisition, so you need to remove the blood at the time you obtain the image. So for you to do that, we have special techniques, but the faster the scan is done, allows us to minimize the time that you need to remove the blood from the slit. So an injection of contrast allows us to obtain an image during that time. Now, one of the challenges has been the Circle Willis, because you can have blood coming from different directions. So we are learning more and more how to improve our imaging. In our studies, this is the equipment we have used, but as I mentioned to you, I would not sure if I would start with this. I would wait until this new technology becomes available and you're able to use a much smaller catheter than you see here. This is a relatively large system, but the way this works is basically you place across the lesion, and then the inside of the wire or the catheter, a light source will go up and down. This is in a cadaver. You can see the basilar artery in a cadaver, and then you can see the light moving down the vessel. So this is how the beam or artery scan, the light goes up and down the wire or the catheter, and the image is obtained at the section where the light is as it goes up. But as you do this, you have to clean the lumen with contrast or saline so that the image is clean. Sorry. So this is a little bit of a comparison between the intravascular ultrasound and OCT. OCT is at the level of histological information. So as you do an OCT imaging, you're looking at the vessel as intima media. It's a different level of imaging. That's why I think that is the next level for us to decrease our complications. We're going to see more. You can see the perforators. You can see, but the problem here is penetration. We cannot go too deep. So you have about a 6 to 7 millimeter scan. So if the vessel is too big or there's an aneurysm attached to it, you may not be able to go deep enough into the aneurysm. In that sense, the IVUS does have a better technology in terms of how deep you can image the vessel. But the precise vessel measurement, it's something that you'll be pretty amazed how our conventional techniques are not giving us necessarily the best sizing. And we all know that sizing for flow diverters does have an impact. The other thing is this amazing image of the origin of perforators and the interesting findings. I never knew that a perforator the ostium, internal ostium and the external ostium were not exactly the same plane. They actually, the artery travels within the vessel wall and comes out in a different angle. So the internal ostium and the outside ostium of a perforator. So Naji showed us beautiful pictures of mini aneurysms on perforators beyond the vessel, but we cannot see in the vessel the perforator, and this is what we're seeing here. This picture is actually in the vessel wall. You're observing the trajectory of a perforator, but this allows us to also see the relationship between the branches and the devices that we place. If we can actually choose, we also saw today top of the basilar flow diverters. Maybe the nice thing would be to map that area and see the amount of perforators you have and decide what kind of coverage you can use. And if you talk about coverage stents, even better, you can then choose which territories you can place the device based on a true imaging, allowing you to see what the vessel looks like. You can make diagnosis of injury like intimal tear as well as plaques and if you're in a true lumen or not. Now, this is the look of a basilar artery with a pipeline, and you can see the relationship of the little tiny struts. So now you can design devices that will have the best shape into the vessel. We cannot see this type of picture very easily unless you do histology. But imagine this type of picture now in a very dynamic world that you can actually follow over time in the same individual, in the same animal in the case of our study. So this is a comparison between an enterprise and a pipeline, how the difference between a low coverage, maybe a 6% metal to artery, to a high coverage, 30% metal to artery, the density of the struts is very different. And this is actually a case that we're able to get an IRB approval to do, was a multiple stents with coil in a human, a live case, that we had to stop the aspirin Plavix. So we wanted to make sure that the endothelium had completely covered the construct. This is relatively early. It was maybe about 3 months from the intervention. And you can see that the neointima had formed completely throughout the stent. We can actually measure at the length of the device that it has been completely healed and potentially be very safe to stop aspirin Plavix. Now, this is, of course, opens up to, if you go to bioabsorbable stents and different technologies, that you can now follow up how the absorbing factor is taking place in the healing of the device. So imagine how much more we can do if we can actually see this. Now, I would like to start focusing a little bit more on what we did, which is the study of endothelization is very appealing to me. And this is an example comparing different devices, and you can, this is the stent you can see here, but you can see that this is the number of frames. So each study may have over 280 or 300 pictures of a millimeter difference of where a histological section. It's actually very difficult for you to do a histological comparison because the macrotome cannot cut the device as close as the OCT can do. So you get much more views of the device. Now this is the example that we found out to be extremely relevant for the evaluation of new devices, is if you have on day 0 and day 21, and you bring this animal for studies in different time points, in this case was every week we're doing that, you can actually see in the same animal the growth of the tissue over the device, over time. And this is what this is showing to you, is basically going from no coverage to complete coverage of the device, and you also can see where the nail intima starts in the healing. And this is now, we're moving to a better visualization of this with this type of reconstructions here. So this is a three-dimensional OCT. So you can see the lumen of the artery, and then you can see the nail intima starting to cover the device until complete coverage. And that type of reconstruction is something that allows us to think about other things. You can now do potentially a flow dynamics study knowing exactly where the device is in place. So by knowing the strut position after deployment, you can use that for CFD calculations in a way that we couldn't do before. Most of this is done as a virtual modeling, and when you place the device, you place a fake device or a virtual device inside of the blood vessel. But having the true detachment of the device measured like this allows us to give to the computational calculation a much better idea of how to simulate that. And this is the type of views you start seeing. Now there's something very interesting about this, which is, let me show you this picture here, which is a reconstruction of the device with the ostium of all the vessels that are in relation to the device. But the most exciting thing, and I think you really should pay attention to this. Look at this. This is the vessel, and right here you have in microns the distance between the vessel apposition in microns in the different parts of the stent. So if it's white, it's well opposed, so you don't need to angioplasty. But if it's yellow or red, so you see the red area here, that means that it's more than 300 microns away from the wall of the artery. So if you have more than 300 microns, in cardiology today, this is an indication for angioplasty. So you can actually get a quick view of the whole vessel with the stent deployed with color coding in the areas that is separated from the blood vessel wall. And that will give you an incredible map of where it's relevant to angioplasty, not just angioplasty everything like we do today. So this is how it looks like. The white is well opposed, yellow is a little bit less, is about 200 microns, and red is 300 microns away from the vessel wall. This is how it looks. So 200 microns well opposed and 300 microns away. Now, this is another great view. This is with a Fred device across an ostium of a perforator. Look at how many little struts, because it's a braided device. So it has it's a multi-layer device. You can see the difference in the strut size across the ostium of the perforator. And this is really interesting. You can measure, you can work on understanding the relationship of this device to the ostium. This is a branch, not a perforator, but you can see the jailing of that branch and how little you cover the ostium of that. You can actually calculate the area that you've been covering your perforators and branches. Okay, now, this is going to go quick, but I wanted. This is really exciting, though. We had an opportunity to study shield versus pipeline versus solitaire, and we decided in an animal model you use a pig for that, and the pigs were. We chose basically two groups: one with dual antiplatelets, and the other one with single antiplatelets. And so this is the protocol. They all receive, I don't know if you know how you give aspirin Plavix to a pig, but we use donuts. So you put inside of the donut, and they eat the donut and the aspirin Plavix. So it's kind of interesting. They have preference what kind of donuts they like, so it's very picky. But this is how they look like. So this is in the lab. We do general anesthesia for the angiogram. This is our procedure. You just get them prepped up there. This is the procedure, the endovascular part of it, this is, we use Navion, Marksman, and the OCT catheters from the Dragonfly Optis from St. Jude. And we randomized, so we didn't know, we placed in the carotid arteries if it was flex, shield, and solitaire. We were blinded to the shield and flex combination. So this is the system we use, over 14 guide wires, a 2.7 French catheter. So the main issue about this, I won't discuss too much the OCT process, but the femoral artery access is a bit of a challenge sometimes. We would go ahead, do an early OCT post-deployment, and then we'll bring the animal in different time points up to 21 days. 21 days, every one of them was completely healed. For the femoral artery, we usually tried, the cut down seems to be the best method to do. This is a little bit of the anatomy. We can go over that if you'd like to do it. But the main thing here is that, yes, the carotid artery is a very straight shot to get there, and each animal got 4 devices, 2 in each side. And this is how they look like post-deployment, the distal and the proximal one. And this is now us doing the OCT during the this procedure. This is very important, which is the flow rate, the injection of contrast to clear the blood. It has to be, there is a science to that, how much volume and what is the rate to use for that to happen. And this allows us to get this kind of pictures. You have the flex, the shield, and the solitaire. And this is in the different regions. This is the one that we're looking at, 100 frames. The 100th cut within the device. This is what these 3 devices look like in the day 7 placement. And this is now at day 21, showed complete coverage of the device and well healed. But let's see what how this looks like in how you compare it and how beautiful. I mean, these images are very clear. As you can see, we're able to remove the blood very well there. And this is now the beginning of neointima growth at 7 days. You can see a little bit of neointima over there. You see that? It struts, it has a little bit of coverage, and it's very symmetrical on the shield. And I'll go over this with you. And this is at day 14, a little bit more. And now at day 21, and you can see the angiogram and the DSA as well as the reconstruction matching very evenly how that growth of neointima was happening. And then we did a histology, and even in the cases that there was thrombus, it correlated very well with the histology and the OCT. So I think this is a very good, but of course this is the limitation of histology, is only one time point. We are able to now obtain data from the acute stage all the way to the histology time using OCT. This is an incredible finding, which is the growth of neointima on top of the blood clots. And this is what I think Dr. Henkes was alluding. Sometimes you'd see a stenosis that goes away. Maybe it was just clot on the wall of the stent, and we definitely saw that happening here. Let me describe to you what we measure, and this will show you the comparison. So we measure the lumen area, which is the green line. The white line is the stent area, and then where we have this black arrow here is called the maximum thickness. And then in this area here, the red one, is the minimum thickness. Now, this is the definition from cardiology of what is a coverage. And then the coverage struts are this type 3 and 4. So you have different ways this has been well established. So we follow that cardiology convention. And we measure this type of, this is the data that I'm challenging you to say maybe new devices should be evaluated like this, is the neointimal ratio, which is the lumen minus the stent area divided by the stent area. The endothelization ratio is the type 3 and 4 that I showed you, and this is the important how fast that happens. And the thickness ratio is, for an aneurysm, imagine, is how much you separate the lumen of the vessel to the aneurysm, and that is the minimum over the maximum thickness. Now, just to show you the OCT data on the patients with the animals with single antiplatelet use, and this is the information we got. I will not, I will kind of summarize this for you, but I'll be glad to discuss this in more details if you have interest. But the interesting things about this were that the no intima formation over time, it was clear that at day 21, everyone had no intima. But from the beginning, which is very surprising to us, the surface modified device had the fastest growth of no intima. And this is something that was against what I expected. I thought that the surface modification would delay the endothelialization. This for an aneurysm perhaps would not be a good idea. But in this case, it seemed that we saw consistently faster endothelialization on the shield device. But over time, it catches up and the other ones will heal. Now, there are many theories why this happens. It may be because the steps of healing are bypassed when you do a surface modification. The device is already pre-ready and can start endothelialization at a faster pace than the ones that need to be first go from a more premature state of healing, perhaps. By the surface modification may change that. Now, the no intimal formation percentage on each position over time. So we checked distal, middle, and proximal portion of the stent and compare if there was any healing happening in different locations. And that proved to be very random. So if you ask today where the endothelialization starts in a device, you cannot say that starts from the edges. People say, everybody says, it starts from proximal and distal. It's a random process. You cannot prove that consistently starts from each end. It randomly starts, and this suggests that this is something from the blood that implants on the device and then develops the endothelialization, not that the endothelialization starts from each intima on each side of the device, which is an interesting finding for us too. The other thing is this is just going on the same type of information I just shared with you. It's very random how that happens. For each device, Solitaire, Flex, and Shield, we saw the same random pattern of growth of no intima. Now, the no intima thickness ratio, it was very important to say that the Shield had the most significant thickness of no intima on day 21. And when you combine the single and dual antiplatelet, and now here you can look at the differences of thrombosis, and maybe this lower part is the most interesting, and I'll summarize this for you as we move forward here. And this is the view if you have single antiplatelet versus dual antiplatelets, the difference on the no intima ratio. You can definitely see that there may be a difference by using single antiplatelets on how the no intima heals over time. And this is the graph showing that there is an earlier initiation of endothelialization on a Shield device, and this was shown when you combine the groups also. Now, thrombus formation, that's the biggest question, I guess, is clear that when we use single antiplatelets, the black one, the Flex had 100% of thrombus on the stent struts. But in the Shield had with a single antiplatelet much less, a significant less thrombosis. And if you use dual antiplatelets, then it becomes all equal. So it's hard to see the difference in surface modification when you're using dual antiplatelets. But if you use single antiplatelets, you see a difference between them. Now, to conclude, is basically I'd like to challenge you if you think that optical coherence tomography could be a new way to assess the new devices, especially in the parent vessel. I think when it comes down to the Shield endothelialization, we show that there is a tendency for earlier no intima formation. We also showed that the volume of no intima formation over the Shield in day 21 was not significant compared to Flex. So over time, they become similar, but it starts sooner with the Shield. We also noted that there's a more concentric, a more symmetric healing of the no intima in the Shield device compared to the other ones. And the pattern of no intima formation is random. This is a very interesting finding. We also noted in the acute phase, there was 100% thrombosis in the Flex device, and there's 2 out of 6 on the Shield device, and that was also an important finding. We changed the protocol because we saw in the acute phase thrombosis, so then we started giving dual antiplatelets, even though we had originally started single antiplatelets, because we had proved the point that there was a difference between them. So after we started doing dual antiplatelets, then the Flex and the pipeline Shield behaved the same way. So there's no more thrombosis after dual antiplatelets were used. Thank you so much. I invite you to come to WNC in Los Angeles in May 15 to 17. We're looking forward to a very lively discussion of cases. And I have to put a plug to Neurovascular Exchange, which is really an educational platform. It's a free online registration. I encourage you to check this out. And this meeting is actually being broadcast live as we speak to this site now. Thank you so much.
Thank you, Demetrius, for this amazing presentation. Have any question in the audience?
Well, first of all, congratulations for this great talk and this new technique. I was wondering, I have a couple of questions. The first one is, do you think this technique, the OCT, it's useful for make the diagnosis of blister aneurysms? Because a lot of times when we perform the angiography, we see those irregularities that we are not sure if it's a blister or not. What is your experience with this technique? Thank you.
I don't have experience with blisters, but I think that this is if we increase the safety, unfortunately, it's an invasive method to prove that. Maybe you can argue that having to do an angiogram. So the fight here, or the debate, is between MRI wall imaging versus intravascular imaging. So if the non-invasive technology gets to a level that you can do imaging of the vessel wall with MRI, which we're seeing more and more of that, perhaps that would be the preferred method for that in an acute case. But no doubt, you have a histological information. You could argue even to do a screening of vessels to see where there is 2 layers versus 3 layers, for example. So predisposed, if you have familial aneurysms, and you can actually make an argument for that, perhaps. This is far from where we are now. I think that the initial application of this will be mainly on treated cases to follow endothelialization and so forth. But I think that the images are incredible, but it's an invasive method to do so. So you have to balance that.
Thank you, Demetrius. Why you are the different thickness of endothelialization? Do you think it's to the flow component, change of the flow, or why? Why is different? I see in the image you are more endothelialization, no in the neck, in another side. Why? What do you think?
Well, I think that the response we're learning from this, but what's interesting for me is that I don't know if there was more opposition against the wall causing more response. So if we see this in the carotids, if you place a carotid stent, many times looks on follow-up that the stent is outside of the vessel and the contrast column is in the middle, but there is a thickness of neointima that grew. There is a tendency for the blood vessel to reconstruct the neointima to the original size of the vessel. So if you have oversized stent, it will narrow enough. It's called late loss, which is the growth of neointima inside of the device to compensate for whatever radial force that you apply against, or angioplasty or stent force. So it may be a component of that. We noticed that not only there was a difference in growth in neointima, but also the symmetry of the 360. Sometimes there is thicker in one side and thinner on the other side on the same cut. And we don't understand that very well. It could be that there is clot in the stent, and that made the neointima grow over that. It became more. So we saw in some cases that as an explanation. There was a coverage of neointima over clot. And the other reason may be related to the strength of the opposition or how the device is deployed, technical issue, maybe.
Okay. The second question is, when I stop the endothelialization, how many days, how many? So you are study this?
Yeah, so in the animal model, it's 21 days. But
1 day to start and stop?
Then we stopped, yeah. But once you finish complete coverage of the device, we didn't see any, we didn't follow long enough to see if there was overgrowth of neointima. Perhaps you could argue that you could look longer for stenosis then. So with this study didn't mean to look into that, but I think that is an interesting question. If we had a device that caused a lot of long-term stenosis, we could try to study when that happens, and I think that's a possibility.
Finally, I suggest you it's possible to put the endovascular device to see the ultrasound, to see the endothelialization. It's possible to put this material and no remove. You wait 1 week and you learn you need what growth endothelialization. It's possible this?
I think it would be not advisable because of the vascular access. You'd have to be still, right now it's not a wireless situation, so you would have to be coming outside of the body, so the patient would be very limited in what they can do. In an animal study, it's hard to justify that type of, even the multiple angiograms. So if you ask me what was the biggest barrier we had, well, number one was to get all the devices and the cost of this, but the other one was the issue of to convince the IRB of a project that you have to do multiple interventions. It's a bit of a challenge sometimes, and but I think that if we show the reason why we're doing this is incredible information. We never knew before where the endothelium starts to grow. You know, this is new information. We also don't know the impact of a new device with a surface modification. So I think that if we have a relevant question like that, it's justified to do multiple studies. I don't think that leaving the wire in place will allow the mobility between the time points. You can extrapolate if it's something that heals very fast, like your stem cells or something. Maybe you can argue that I want to monitor in an hourly basis, and then you can justify a design that you could do this. The issues would be the anticoagulation that you have to have and the mobility and the anesthesia time. You know, a pig, you know, once you wake them up, they're not going to hold, they're going to be all over the place, you know, and I think that's the limitation of that. Thank you.
Thank you, Demetrius.